Good evening, everybody. Good evening, good day, good night, wherever you are, whatever time you listen to this. We're going to go over some bleeding, chapter 26. I think it's 25 in your books or however I got it listed on JB. Not real sure. Just make sure you look for bleeding. I'm going to cover some things and then we'll give you your code. So we know trauma applies the fundamental knowledge to improve basic emergency care and transport-based assessment findings for an acutely injured patient. We're going to talk about bleeding, the recognize and management of patho assessment and management of bleeding. Pathophysiology applies to the fundamental knowledge of the pathophysiology of respiration and perfusion to a patient assessment and management. Recognizing bleeding and understanding how it affects the body is a very important skill. Bleeding can be external and obvious or internal and hidden. Other type of bleeding is potentially dangerous and can cause weakness, shock, and ultimately death. Uncontrolled bleeding is the most common cause of hyperfusion following a traumatic event. The cardiovascular system circulates blood to all the body cells and tissues. This does deliver oxygen, nutrients, carries away metabolic waste products, response. It is responsible for supplying and maintaining adequate blood flow. Again, so here's a cool chart of how it pumps and flows, how it brings in good blood to dirty blood to back to the heart to where it is super cool on how the body functions. So we know ultimately the heart is our pump. All of the blood vessels are the container of all the fluid we have. And obviously the fluid is the blood and bodily fluids. So the heart needs a rich and well-distributed blood supply. It has two separate pumps. It has the upper chamber, the lower chamber. Remember, those are your atrium and your ventricles. That's very important for you to know. Blood leaves each chamber through a one-way valve. So what happens is those one-way valves shut to where if there's any type of back pressure, those valves shut, which does not allow blood to flow backwards. So this figure shows the right and left side of the heart. As you can see here, this is the right ventricle down here, how the blood flow comes in, coming around, goes back out to the left pulmonary blood. You see how it's coming in here to the pulmonary veins from oxygen-rich blood, comes down to the left ventricle, goes back up to the aorta, which takes oxygen-rich blood to the upper body and head. That's important because we need it. We need that and blood to breathe and live. I like them both. So I'm trying to say I'm addicted to that too. Blood vessels and blood. So there's types of blood vessels. So we have our arteries, our arterioles, and capillaries. So we're going to talk about venules and veins. You see the difference in both of them. One's very small. One carries vessels that carry empty into the veins, and the other one carries blood from the tissues to the heart. So oxygen and nutrients easily pass from capillaries into the cells, and waste and carbon dioxide diffuse from the cells into the capillaries. See how it's functioning right there on the picture on the right. Talks about O2 in the lung alveoles, how the O2 gets back into the body, how it's broken down, CO2 and waste, it gets into the nutrients. So it's the whole pathway of all this, of how the body functions. So we do know that red blood cells responsible for transportation of blood cells and carbon dioxide away from the cells to the lungs. White blood cells, we talk about, there's different kinds. We have our platelets and our plasma. So the white blood cells is responsible for fighting infections. That's the reason why when you get your blood, they always check your RBCs and your WBCs, which is your red and white blood counts. Your platelets is responsible for forming clots. You know, you can also donate platelets if you ever donate blood. And then you can also donate plasma. 3 different types of donations. So just make sure to make an educated decision if you ever give blood on which one you want to give. So our blood clots deforms on the several factors. What is our blood status? Okay, so it's changes in the blood vessels wall, such as a wound, and the blood's ability to clot is affected by disease or medication. Some people have a very hard time in forming clots, and they're given a clot medication to help them build that up. So when tissues are injured, the platelets begin to collect at the site of the injury. It's like an internal Band-Aid, and the red blood cells become sticky and they clump together. So if you've ever seen like somebody had a really bloody nose and they finally move that tissue, it looks like it's just a big old clump of nasty blood. That's a clot. That's the body's way of trying to fix itself. So we have our autonomic nervous system, and it monitors the body's need to adjust blood flow by by constricting or dilating blood vessels. Automatically redirects blood away from the organs to the heart, brain, lungs, and kidneys in any emergency. It adapts to changing conditions in the body to maintain homeostasis and perfusion. If the system fails to provide significant circulation for every body part to perform its function, shock happens. There ain't no way about it. If the body's if it's unable to do it, that's when we go into shock. Maybe it's due to a multi-system trauma, and there's just so much loss of blood that the body is unable to control it all at once. So perfusion is the circulation of blood within an organ or tissue in adequate amounts to meet the cell's current needs for oxygen, nutrients, and waste removal. The speed of the blood flow must be fast enough to maintain an adequate circulation throughout the body and avoid clotting, must be slow enough to allow cells time to exchange oxygen and nutrients for carbon dioxide and other waste products. Some tissues need a constant supply of blood, while others can survive with just very little. All organs and organ systems of the human body depend on an adequate perfusion to function properly. Some organs cannot tolerate an interruption of blood supply for even a few minutes without sustaining damage. Death of an organ system can quickly lead to death of this patient. The heart requires a constant supply. You can't shut off blood flow and get it right back. It's going to have everlasting issues. So what is a hemorrhage? So any type of bleeding is a hemorrhage. External bleeding is a visible hemorrhage. You can see an internal hemorrhage after a few days, like maybe after a couple of hours. You see the bruising. That's an internal hemorrhage. Now, that's not something we're instantly going to see, but that is something over time that we'll be able to reflect on that and say, oh, well, there was an injury right there. With serious external bleedings, it may be difficult to tell the amount of blood loss. Blood will look different on different surfaces. It is important to estimate the amount of external blood loss. The body will not tolerate an acute blood loss of greater than 20% of blood volume, which is basically drops it down to 2 pints. When you lose 2 pints of blood, you start to become very dizzy, you get lethargic, you're just not acting your normal self. I encourage you guys to take like just a regular, go to your sink, get a cup of water, and walk out to the concrete and drop that cup of water onto the concrete. And the reason I tell you that is because now you know, well, even better than that, measure out a certain amount of water and then go drop it out there. That way it gives you an idea, be like, wow, I know what it looks like, what 18, 16, 22, 24 ounces. I know what those are. So it kind of helps you with the ability of learning. Adverse changes in vital signs may occur with significant blood loss. It increases the heart rate, increases in respiratory rate, decreases in blood pressure. So the more blood we lose, the more chances we have of not making it. Our vitals are affected by that, so we have to be cautious. All right, so how well people compensate for blood loss is related to how rapid the bleeding is. So an adult can comfortably donate a 1 unit of blood over a period of 15 to 20 minutes. If the similar blood loss occurs in a much shorter period of time, the person may rapidly develop symptoms of hypovolemic shock. The age of pre-existing health of a patient should be considered. So in other words, I'd say, and the only reason when you go and donate blood, they're only going to take 1 pint of blood from you. and they make it over about a 20-minute period. Some people can make it faster and not have any issues, but majority of your blood services only take 1 pint, and it takes them anywhere between 15 or 20 minutes. That's why they always want you to sit over there, get you a snack, make sure you get your sugar back up. So here's some characteristics of bleeding. So we need to know what the, so you should consider bleeding to be serious if the following conditions are present: uncontrollable bleeding, we have significant MOI, a rapid blood loss, poor general appearance and no response of external stimuli, signs and symptoms of shock, which is hypoperfusion, and then significant blood loss, which we know if you walk up and be like, gee, that's a lot of blood, you would automatically think that they're probably not going to be good and their response is going to be delayed. So arterial bleed, what is the difference? So we need to know the difference between an arterial bleed and a venous bleed. So arterial bleeding pressures can cause blood to spurt and make bleeding difficult to control. Typically brighter red and spurts in time with a pulse. That is a arterial bleed because it spurts with a heartbeat. Venous bleeding is a dark red. It does not spurt. It is very easy to manage. Most of the time it's small and they're more likely to clot spontaneously than arterial blood. It can be profuse and life-threatening, but not as much as an arterial bleed. Here's some little pictures of it. You see these are all capillary bleeding. There's dark red and oozes from a wound instead of steadily, but it is slow. More likely to clot spontaneously than the arterial bleed. So this one down here is an arterial bleed. You see how it spurts? This is more of a venous bleed, and these are capillaries because it's super slow. Now, this is going to be a lot of blood. So is this, the B and C are going to be a lot, but it is not more, they'll have harder to clot than they will for number A, or letter A. So bleeding tends to stop rather quick within about 10 minutes in response to internal mechanisms when it's exposed to air. When the skin is broken, blood flows rapidly from the open wound. The cut end of the vessel begins to narrow, which is called vasoconstricting. It reduces the amount of bleeding, starts forming clots. The bleeding will never stop if a clot does not form unless the injured vessel is completely cut off from the main blood supply by applying direct pressure or a tourniquet. Hemophilia is the patient who lacks one or more of the blood clotting factors. Bleeding may occur spontaneously. All injuries, no matter how trivial or potential serious. Patients should be transported immediately. So if you come up and somebody tells you they're a hemophilia, you need to know that they have the inability to stop their own bleeding. So we need to make sure we transport them pretty rapidly to the facility. Internal bleeding. So we know this can be serious. We're not going to be able to see it as much, but some of the causes we're going to come across is hypovolemic shock. They are losing large quantities of blood, but we just can't see it. Why and where it's at is that's what we have to consider. Possible conditions causing internal bleeding, they can be from broken bones, lacerated livers, stomach ulcers, or a ruptured spleen, depending upon the MOI. Often the only signs of internal bleeding are ecchymosis or contusion. Mechanism of injury for internal bleeding. A high energy MOI should increase your index of suspicion for the possibility of a serious unseen injury. You may have a blunt trauma, penetrating trauma, and you may or may not be able to see the penetrating trauma. It may have something that occurred and then was removed. So remember again, our DCAT BTLS, we've talked about that. You should know those forwards and backwards. Internal bleeding is not always caused by trauma. It does have possible non-traumatic causes. You could have some bleeding ulcers, aneurysms, ruptured ectopic pregnancy. I mean, it's not as important for you to know the specific origin, but I do want you to recognize what the signs of shock and how they respond. Those are the big ones that I want you to pay attention for. So signs and symptoms of internal bleeding, you may have pain, which is the most common, swelling in the area of bleeding. You have distension, Bleeding into the chest cavity or lungs may cause dyspnea, tachycardia, or hypotension and hemoptysis. And we'll have hematomas and bruisings. Bleeding from any body opening. Bright red bleeding from the mouth or rectum. First off, the face is going to bleed pretty profusely because it's more venous. You're going to have more veins to the surface. So any cut to the face is going to be more, it's going to be more bloody. So hematemesis is a vomiting of blood. You have bright red or dark red. They do have a coffee ground appearance. Melena is a black, foul-smelling, tarry stool with digested blood. It's gross. That's all I can tell you. It's gross. It's going to come across with pain, tenderness, bruising. They'll have guarding or swelling. You have possible closed fracture there. And broken ribs, bruises over the lower part of the chest, or rigid, distended abdomen. So hyperperfusion or hypervolemic shock. You'll notice change in the mental status. They'll have be very anxious, restless, or combative. They can be faintness, weak, or dizzy on standing. You'll notice some changing in the skin color. Later signs of hyperperfusion suggest internal bleeding is going to be tachycardia, weakness, fainting, or dizziness, even at rest. They're always thirsty. They have nausea and vomiting. Most of the time they are cold, moist, which means they're kind of like sticky. They got that clammy, like, oh, that's gross, don't touch me kind of skin. And then slow, rapid breathing. They'll have the dull eyes. It just looks like they don't have that glossy appear to them anymore. They just look very dull. They have slightly dilated pupils that are slow to respond to light. Their capillary refill takes longer than 2 seconds to come around. They are weak. They have that thready pulse. They have decreasing blood pressures because there's a blood loss somewhere. Obviously, our blood pressure is going to decrease too. Patients with these signs and symptoms do require prompt transport. Patient assessment of external bleeding. Scene size up. We need to know, is the patient a potential hazard or not? In a violent incident, make sure the police are on scene. Follow your standard protocols. What your company requires you to do must be followed at all times. Consider the mechanism of injury or illness. Consider the need for spinal transportation, spinal immobilization. And do we need additional resources? Do I need some help? Am I going to be able to control this person? Do I need somebody to come help me? On our primary assessment, do not be distracted from identifying any life threats. Form a general impression and note important indicators that alert you to a seriousness of the patient's condition. If you think they're serious, treat them as serious. It's okay for you to make that impression and do your job. If the patient has obvious life-threatening external bleeding, address those first. Don't pass go and collect $200. You need to make sure that stops. What is their skin color? Determine their level of consciousness. And we know we've talked about using the AFPU scale. Ensure that the patient is breathing. Provide high flow oxygen or assist ventilations with a BVM or non-rebreather mask. Insert an oral or nasal airway to secure the patient's airway if they're unconscious. I know it says oral pharyngeal, but you also need to remember a nasal airway too. Circulation, assess pulse rate and quality. Determine skin condition, color, and temperature. Check capillary refill times, control external bleeding, and treat any signs of shock. On our transport decisions, we just talked about that in the last chapter when we talked about trauma. We need to know, or is it time to go or we stay and play? Patients who may have significant bleeding will quickly become unstable. Are you willing to let this patient die on you? Or do you want to get them out of your hands? Get them to the facility that they need to be as quickly and safely as possible. Signs that impede the need for transport. What does this? I need something to tell me. All right. So here, tachycardia or tachypnea. We have low blood pressure, weak pulse, and their clammy skin. Those are signs that ideally need you to rapidly transport this patient. On our history of questions, do they look for signs and symptoms of other injuries due to an MOI or an NOI? Some things that just go ding, ding, ding. This is not normal. Listen to your guts. If your guts say, hey, I don't feel so comfortable. I want to get this guy to a facility. I want him out of my care. Then let's get him. Let's get him there. What does our sample history tell us? Determine how much blood has been lost. Well, you won't know that. We don't have the little valves that tell us how much blood we've lost on a person, but how are they responding to us? Their alertness level. What is their blood pressures? Is it just not, are they poop over poop when you check the blood pressure? Well, that ought to tell you right there, something's wrong. Ask the patient about blood thinning medications. Those are very important part of information on your sample history. On your secondary assessment, on your abdomen, your head, abdomen, and extremities, look for uncontrolled bleeding from a large scalp laceration. Feel for all four quadrants of the tenderness or rigidity. Are they guarding their abdomen? Extremities, record their pulse, the motor and sensation functions. Do your vitals. With a critically injured patient or a short transport time, there may not be time to conduct a secondary assessment. And it's okay. You're not going to get in trouble because you didn't have time to do a secondary assessment. You will get in trouble if you didn't try to do something for that life-threatening blood, that ooze that you didn't pay attention to. If you keep squirting every time you take a heartbeat, well, you didn't fix that, and your 5-minute transport time, that's neglect. Reassessment. Again, we're going to reassess them every 5 minutes for stable patients and every 10 to 15. I'm sorry. We're going to do a 5-minute assessment for unstable patients and 10 to 15 minutes for unstable patients. It just depends on what your agency requires you to do. You're going to always reassess those signs and symptoms. You're going to check your blood pressures. You're going to start from the top to bottom every single time. If you've done something, make sure you reassess it. Make sure that treatment has helped the patient out. Is it getting better? Is it getting worse? We need to know. Interventions. Some of the things we're going to do for them. We're always going to put any patient on high flow O2. Have we controlled their external bleeding? Provide treatment for shock if it's applicable, and we're going to transport very rapidly. If there's internal bleeding is suspected, apply high flow O2 with a non-rebreather mask and provide transport. Do not ever, 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 ever delay transport of a patient to complete an assessment. If you recognize it and realize, hey, they got an internal bleed, get gone, cuz we ain't waiting on you. Anytime we do this, we need to recognize and estimate and a report for the amount of blood loss, just depending how much we think. Obviously, we're going to tell our staff at the hospital, we're going to tell them, hey, we're coming in with a large quantity of blood loss. I'm unable to control the bleeding. I've tried tourniquets, I've tried blah, 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 blah. Relay all of that to the receiving facility. And again, if you have to document every bit of your care, treatment, all that, and all that needs to be done in a timely manner. Remember, I've said it multiple times. If you didn't document it, it didn't happen. If you did it and didn't document it, it didn't happen. All right, follow your standard precautions. Always wear your gloves, your mask, your eyes protection, your gowns. Make sure the patient has an open airway and is breathing adequately. If not, you can drop nasal or oropharyngeal airway. Always provide high flow O2. And we're going to control obvious life threats of any type of bleeding as quickly as possible. That is very, very important that we do that. We know that we can do direct pressure. We can elevate the injury site if it's on an extremity, or if it's anywhere else, we're going to apply direct pressures or splint it. We use tourniquets at the last resorts. If you don't know how to do hemostatic dressings and your agency allows it, make sure you ask for them show you for examples. And wound packing is also an option. If you're uncomfortable on doing that, you need to get some extra training on that from maybe your agency. If they don't allow you to pack a wound, then don't do it, because then that's stepping outside of your protocols and procedures, and then you're treating the patient on your own. Direct pressure is exactly what it means, direct pressure. It is the most common and effective way to control bleeding, but it does apply pressure to stop the flow of blood, and it prevents the normal coagulation to occur. For an object protruding from the wound, apply direct, bulky dressings to stabilize the object in place and apply pressure the best that we can. Hold uninterrupted pressure for at least 5 minutes to try to start the clotting process. Firmly wrap a sterile, self-adhering roller bandage around the entire wound. You're going to stretch the bandage tight enough to control the bleeding, but you still should be able to palpate a distal pulse on the injured extremity after applying the dressing. Do not remove the dressing until a physician has evaluated the patient. Apply additional manual pressure through the dressing. If it is necessary, apply more dressings over the first. Do not take it off and apply more. If a tourniquet is useful, if a patient has sustained a bleeding from an extremity injury that cannot be controlled by direct pressure, apply the tourniquet above the level of the bleeding. If it is not possible, to consider a junctional tourniquet or wound packing with hemostatic dressing if available. You should be able to look in your book on 2.6-1 to show the basic techniques of controlling external bleeding. So on wound packing, gauzes can be packed into a larger wound to control a hemorrhage when direct pressure is not adequate or application of a tourniquet is not possible. Hemostatic dressings is impregnated with a chemical compound that slows and or stops the bleeding by prompting clot formation. It can be used together with wound packing and direct pressure when direct pressure alone is ineffective, or when a tourniquet placement is otherwise impossible. You can also look on 26-2 to demonstrate the basic techniques of packing a wound. Tourniquets, if direct pressure does not control the pressure, bleeding, apply a external commercial tourniquet, and then make sure you secure it. So junctional tourniquets apply for proximal compression of life-threatening bleeding in areas where standard tourniquets application is not possible, such as the groin or axilla. And this may be indicated by severe hemorrhage or to the junction of the torso with the arms or legs. Some junctional tourniquets may be used as a pelvic binder. Be very cautious when you do that. You need to make sure that your agency allows that and that you have been trained properly before you use these tourniquets as a pelvic binder. So here's a picture of an air splint. I have never used an air splint, but it is just like it's basically a bag that you're putting over there, and you're going to apply around in here somewhere is a air inlet, has a little pump, and it pumps up and applies pressure around there. These also can be apply for pressure dressings if required. Air splints is the same as that thing. It applies direct pressure applied to internal extremity rather than to a small local area like we just showed. A pelvic binder. So here, a pelvic binder is a type of splint that may be indicated for a suspected closed unstable pelvic fracture. All the agencies I've ever worked for have never had one, so I've always used a sheet. You put a sheet underneath the patient and you tie it very tight around their pelvic. It's the best ones I've ever used. So get some of your old hands and some of your agencies to show you how to use them. They're freaking amazing. And those are the ones that I like to use better than anybody else. Obviously, bleeding from the nose, face, and mouth is going to be copious amounts of blood. You may have skull fractures. You'll have busted, broken nose. High blood pressure causes this. Digital trauma, some cancers. My son has frequent nosebleeds from his nose. He's been cauterized multiple times. Sometimes it'll just start no reason whatsoever. He doesn't have high blood pressure or anything like that. When he was younger, we always thought it was because he kept his fingers in his nose, but over time, it has just created weak blood vessels in his nose. Ataxis, which is nosebleeds, we talked about that. They are commonly caused enough for a blood loss to lead to shock. The blood you can see is only a small portion of the blood loss. Much of the blood may pass down the throat into the stomach as the patient swallows. Remember, if they do this, it potentially can make them very sick and very nauseous. Most non-traumatic nosebleeds occur from the sites of the septum, the tissue dividing the nostrils. You can usually handle this type of bleed effectively by pinching the nostrils together and having them lean forward. Don't like them lean back because they start swallowing that blood. I don't want you to vomit on me. I'm good. This may bleeding from the nose or ears following a head injury will possibly create indicate a skull fracture. Do not attempt to stop the blood flow. You want to apply excessive pressure to the injury and may force the blood leaking through the ear and collect within the head. Loosely cover the bleeding site with a sterile gauze pad to collect the blood flow to keep contaminants away from the site. And you can apply very light compression by wrapping the dressing loosely around the head. Here's right here is a sign of cerebrospinal fluid. You see that it forms the blood around in the center. You can see the clear fluid around the outside. That is a spinal fluid that we need to be very cautious about. Transport that patient with care and rapid transport. So emergency medical care for internal bleeding, basically keep the patient calm, reassure them that everything's going to be okay. Just let them be still. High flow O2, splint the injured or extremity if it's needed. Never use a tourniquet to control bleeding from a closed internal or soft tissue injuries. Look on skill drill 26-5 to discuss about internal bleeding. And that's what everybody wants right there. 6%, 93, and 3. That is your class code for this evening. I hope everybody has a wonderful time and good luck on your test. And I will see you at the next class appearance. Everybody have a wonderful day, evening, or night.